MARIAM SHEROZIA, and I'm a PhD student, as Dato mentioned. And today I will present my pre-implementation study, on feasibility and accessibility of using HIV self-tests among people who who inject drugs via SVM. It doesn't work. Okay. So, implementation challenge is that Georgia has one of the highest rates of injection drug use. And beside this fact, only third of the people who inject drugs are engaged in prevention programs. And additionally, we have main gaps among PWID related to HIV self-testing. And in 2022, there was this biobehavioral surveillance research, and this research showed that only 44.6% of PWIDs reported HIV self-testing in the last year. So as we see, we have main gaps in HIV testing, and also I want to mention that among general population, among those who were HIV positive, more than half of those population were diagnosed at a late stage. So as we see, we have not only challenges related to HIV detection, but also in timely diagnosis. So my goal is to assess the process of distributing HIV self-tests among people who inject drugs using two different kinds of models. One is syringe vending machines, and another is needle and syringe programs. So here you see one of the 8 syringe vending machines which are operational in Tbilisi, Georgia. And those syringe vending machines started working in 2020, and they are working 24/7 and distributing different kind of paraphernalia for the beneficiaries of harm reduction services. And as you see, it is covered with the hepatitis C and also immunization information for the privacy of those beneficiaries. So upper 2 shelves are for sale for general public, and there also we have lower 3 shelves for the card holders. We call it Sigma cards, which are distributed among people who inject drugs via needle and syringe program service providers. Yeah, and here you can see the Sigma card, which opens this so-called hidden menu, which is not seen for the public, for the general population. So my study is grounded in implementation science. In the previous days, we talked a lot about different kinds of frameworks. And here you can see one of the frameworks, which is conceptual framework, and I will use it to guide my qualitative focus groups. And this one is especially modified version by Sermon, which adds extra 6 dimensions to the availability, accessibility, accommodation, affordability, and acceptability topics. And this specific conceptual framework will help me to assess how the services, if the services have ability to match the needs of the people who inject drugs, so the beneficiaries of those services. So when it comes to implementation framework, as I mentioned, my study is pre-implementation study. And in order to evaluate the process of delivering those HIV self-test kits, I'll use REAM framework, which was mentioned by Rick today and in previous days by the Professor Luke Davis. And for the specific case, I just remind you what REAM stands for. This is reach, effectiveness, adoption, implementation, and also there is maintenance part. But for my specific research, I'll focus on those 4 dimensions which are presented here. So evidence-based practice, as you heard, HIV self-testing will be the main focus of my research. And HIV self-testing first was developed to increase the access to the HIV self-testing, specifically for those populations who are underserved or who are a part of the hard-to-reach groups. So as research suggests, 6 out of 10 people who have HIV, they don't undergo like the regular facility-based services. So therefore, it seemed the SVM and those type of service delivery could be really reliable service model for those kind of for this type of cases. So as for my methodology, as I mentioned, my main aim is to evaluate the process of distributing HIV self-test kits and compare to models of delivery. And it includes the core 4 aim, which is exploring adoption of distributing those test kits, also evaluating the implementation of HIV self-test kits, also assessing reach and measure the effectiveness of distribution. For the first 2 dimensions, what I'm going to do is that I will conduct some qualitative data among service providers as well as PWIDs who are engaged in those type of services, I mean the harm reduction services, and also among the PWIDs who are not part of the needle and syringe programs or who are not using syringe vending machines. And for the second part, I would say those reach and effectiveness will be my secondary outcomes. I will use the program records from needle and syringe programs as well as from syringe vending machines. And I would like to use this opportunity to say thank you to the Alternativa Georgian Harm Reduction Network for providing those data. Okay. As my early findings, before I will describe these tables, I would like to mention that my study is still on planning stage, and I'm working on my ARB documents, and after the approval, I will start collecting some qualitative data among those service providers as well as beneficiaries. So at this moment, what I have is some service data from needle and syringe programs. There are 5 centers in Tbilisi, and here is provided data from all of the centers, and also data from the syringe vending machines. So as we see, in 2023, needle and syringe programs distributed more than 250 HIV self-test kits, which is, and syringe vending machines distributed double as compared to needle and syringe programs. And also what we see is that in 2024, SVMs reach more women, like 63 compared to needle and syringe programs. And also it's identified in 2023 6 cases of HIV, 6 cases of HIV. So yeah, I forgot to mention, should I go back and show the, so on the SVM, we have this LSD screen, and when someone gets the, when someone withdraws the HIV self-test kit, and after that, when he or she does this test and got some results, after she comes for another test to withdraw from the SVM, I'm not sure if I like describing correctly. Yeah, after she comes second time, then on the LSD screen it pops like small questionnaire if he or she did the testing and what was the result. So those positive cases are from the reported reported cases from our beneficiaries. Self-reported, yeah, from self-questionnaire. Yeah. So questions as I said, I'm still on the planning stage. So I have some like questions for our discussions to discuss with the audience, because there are a lot of people who have different kind of experience working in implementation science and doing implementation studies. So first thing what I'm going to do in terms of conducting focus groups, I'm thinking to use this mixed method approach. I'm going to do focus groups and also use nominal group technique to gather some information about facilitators and barriers which are related to HIV self-testing. So I would love to hear some like experience which has audience, if it's like the proper way to use both type of approach at the same time. And also, as you saw on the methodology slide, my primary outcomes are related to adoption and implementation. And I'm not sure which kind of like quantitative indicators would be best to capture those dimensions. And also third, like discussion question will be, if there are, for the statisticians who are here, if there are like some recommended R packages and also some models for this specific case, which are related to service records. So before answering and discussing these topics, which I mentioned already, I want to wrap up my presentation. So as I mentioned, currently I'm preparing my IRB documents, and after approval, I will start collecting qualitative data. Also, I have some quantitative data from the service providers from Tbilisi, but there are different years from 2022 till 2021 and 2022, which is still going, like they will provide those data as well. And also, finally, my main aim is to mix those quantitative and qualitative data from my study, and to inform the future implementation strategies to scale up the HIV self-testing services. So thank you. I'll go back, and you are welcome.
Please,
to
questions,
have
comments.
any suggestions.
So I think it's really good just to sort of walk through what's happened here. And so the problem statement is that people who inject drugs don't get tested with the frequency that they're recommended to do. So it's low, 40%. And then the second part of it is that you have a relative advantage of A versus B, which is these
Syringe vending machines
the
and
vending
research
machines
programs.
and the syringe services programs. And so I think that, one of the key things that you want to understand is, are they completely different populations or do they cross over? Now, everybody who gets our syringe services, we have them in a database where we can look at whether they move back and forth between them, so you can look at that. And I will tell you, you'll find out that there's going to be some overlap, but they're going to be, so you really want to know is this new innovation, a different way to get HIV self-testing as the evidence-based practice. Syringe services programs are one. Is this, another one that's doing it? Is there a relative advantage? And are you hitting a population of people who are completely different, or are you just supplementing it? You still want them to get tested. But so you really want, so a lot of your focus group questions are really hopefully going to be, getting at that. There's the first question, when you get people who don't use either of these services, what gets in the way of, getting HIV tested? And then I don't know, I don't care, whatever it is, or it might be I don't know where and stuff like that. So your ultimate implementation strategy may differ, because you may have to do something to actually, they have to know about it first, right? And then so there may be that. So what gets in the way may be one of the first questions. And then some of your other questions that may be used in a different method, maybe not nominal group technique. And I want to be very carefully guiding people to not do focus group discussions and nominal group technique where you just let everybody blurt out, unless your sequence is the nominal group technique, which is very structured. You cannot have a conversation before you do that because you're influencing ideas and you're restricting ideas. So you can't do that, or you shouldn't do that from a scientific perspective. But you really want to sort of get at a couple of those sorts of things. So your nominal group technique will be really good at sort of understanding what gets in the way, and maybe sort of a discussion, what's the relative advantage? And then maybe you get the people who use both as an idea in order to get at that, or then your separate groups in terms of why they don't use the other. And so there's a really interesting sort of way to triangulate those sort of data. And then I would sort of keep my eye on a different prize, and like, how do you move from what they're doing now to what they could be doing in the future? And so that's just, I want you to not lose sight of that, because what you're going to learn from this actually lays the foundation for the next set of things that you do.
Yeah, thank you, Rick, for the suggestions. I will consider the third group of PWIDs to include in my research.
I think that,
Yeah.
What I didn't say at the beginning was, this is really good.
Yeah, it's really good. Thank you, Miriam. I'm going to just add a little bit. I'm going to answer your question directly. You can use the theory of access for question design, right? You can use any theory, but remember, in nominal group technique, the question is really important, right? So think about what you're trying to do. If you're trying to differentiate between two existing approaches and understand why more people don't access it or why they like accessing it, then the theory of access is useful, right? So just make sure that your theory actually matches your research question. Yes. And then in terms of nominal group technique, we have a paper under review at JSAT right now that I would have presented yesterday if the lights hadn't gone out. And it actually shows an excellent use of nominal group technique across different populations. So Rick was beginning to talk about this, right? You want to do nominal group technique with people who don't use the service, any of them. You want to do nominal group technique with people who do use the service. And then maybe another one with people who use both services, right? So if you differentiate your population in some way like that, characterize the participants, you're going to learn more. And what's so fascinating always from my perspective is, what is the overlap there, right? And then you can choose strategies to further understand, like maybe dive into focus groups or that kind of thing to further understand the populations. So that would be just one thought I would have about your first question.
Okay, if I got it right, so you are saying that using those both methods or strategies at the same time is not a good idea. Like,
yes.
But if I start with the NGT technique, got some barriers and facilitators, then I can go deeper.
Yes.
And have some focus groups with those people, right?
Yes.
Okay.
And build on what you learn in your nominal group technique. Maybe you don't need focus groups, but maybe there's something you really want to know more about that rises to the surface in your NGT, and then you can focus there.
Okay, thank you.
When they get to the end of an hour, and it's going to take you an hour to do your NGT, they're not going to want to hang around. You can maybe invite them back for something, but don't compromise your NGT with a discussion, except about the barriers and facilitators that you learn.
Yeah.
You just won't have time. And it's kind of like, data in is data out. If you're getting crappy data towards the end of it because they're tired and they're not there for too long, use those data and say, now I want to learn something else. Bring back some more people. It's much better to do it that way than to try to do it all in one. It's great if you can do it, but you're not likely to get it all done.
Okay, thank you.
Mariam, are you going to also interview out of service
Yes.
PWID?
Yes.
Yeah. Okay.
Yeah.
That's an important thing, because that's the group that you're not getting to in either place. Great.
Thank you very much for such a nice presentation. I want to ask you about linkage to care. So you identify positive cases. Maybe it is not in the scope of this study and your goal is different, but just wondering, are you following to those positive cases? What is the next step? Where they are going? Do you give them notes where to go for the next stage of care, and or are they starting treatment? Or I mean, first for next diagnosis and then to treatment.
Thank you for the question. As you mentioned, it's not my scope of my research, but we can't follow up those people because we don't have any kind of linkage to care part in our implementation, like in our SVMs. But what we have is that there is like the list of service directory, and if they think that the case was positive, they can search for the specific services among those service lists. And yeah, that's the one thing that we can do for them. And also there is this Sigma portal where they can sign in using their card number and specific like information, and they saw if there are like in other services, how can do they HIV self-testing instructions as well and stuff like that. But we don't have like linkage to care at the moment.
Yeah, so just to build on that, for those people who are looking to do research, the question would be if you, because this is a big problem, Dato's not been able to find out what the heck they're doing with their testing. But then you get a group of people who've gotten your self-test and say, all right, first of all, find out, you can do like a quick little survey. Did you use the test? But especially if the ones who've used the test, you could say, it's your status neutral. You either go get PrEP or you go get treated. What gets in the way of going to the next step? That's a really important question, because then you can come up with a strategy. So it's a black box right now. I think, Dato, you talked about that. And for those of the people who are interested in the next step, you got to get them tested first, which is what she's trying to get at, which is really important to start with the most proximal thing, because the implementation strategy that she just listed a whole bunch of them that are being done. They're not working, so you got to do something different. So that's your next question, really important.
And
Mariam, good luck with this study. Just wanted to say to the audience that drug users, especially injected drug users, have very low interest to take HIV self-tests, to continue with linkages regarding that and so on. So we started adoption of this new intervention since COVID, and during COVID time, it was more or less effective, but now we are just making too much efforts to distribute them. And the follow-up is very low, completely no follow-up from it. But I wanted to say, the audience and focus groups that you mentioned, I imagine that you will conduct them among those drug users who have at least once experience of using this. The second focus group should be among those who have never used and has no awareness of, no motivation to use them. And I would also suggest to go and see the insights of sex partners of drug users, because mostly when encouraging drug users for HIV testing, we use this bridge population to bring. We have different peer education sessions for drug users, their sex partners. We provide several kind of incentives, medical consultation, for example, hygienic items, and I don't recall now, but there are multiple packages for sex partners. Maybe we can think how to use this population to encourage HIV self-test use and provide the follow-up. Maybe you can consider in your study design.
thank you, Maka, for your recommendations. We can talk about it after the presentation. So one thing I want to mention that this gift program is really unique because, as you see, there are not like challenges related to one step, but there are a lot of challenges through this way. So I am starting like my research about the HIV testing. There is also Taco, Irakli, Levani, Anzori, and others, Katie, who are doing this whole thing. So it gives us the whole picture, how it starts and how it gets to the end. So I think after the research, there will be some improvements, I'd say. So thank you.
Groups there. You've got the worried well who get tested and they're negative, and they're worried. They're still engaging in some risk and they're anxious. And then you've got the people who test positive who don't believe it and want to check it out again. And yeah, and they don't want it to be true. And that's just a reality. And you know, we've seen this before. It's a really interesting, you know, sort of phenomena. But you know, what you would really like to be able to do is the minute that someone's gets a positive test, that you can actually do something for them. We have a confirmatory test. Some of that may be the messaging. Don't you worry, we've got something. It's all about framing this that may actually make a difference. And we can talk a little bit about framing, but I would be completely surprised if you didn't have those kinds of people, because that's how they are. I mean, I have people who like don't even have sex, or maybe they'll have oral sex once a year, and they're just worried to death all year long, and they're in there getting tested every 3 months, and other people who are doing everything in the kitchen sink and never get tested. So.
Okay.
Mariam, thank you for a wonderful presentation and good job. I have a concern, more concern rather than the question about NGT. NGT is a wonderful technique to identify some barriers and have a bigger picture from the stakeholders or target group. But I wonder, due to the stigma, would PWIDs like to sit next to each other in one room and discuss those things? And is it appropriate technique for your study? Even
So-
though I love it very much.
Actually, among those hard to reach groups, we always have like social desirability bias, but we actually use those NGT techniques among sex workers, among partners of PWID, and those hard to reach groups. So it works really well. And actually, when they don't have the need to describe why they think this way, they are really specific. And I think it decreased the stigma as well. I'm not sure if, yeah.
In many cases, there's a real openness for many populations, but there's going to be some generalizability for the people who won't come in. I'll give you some examples. In Malaysia, where homosexuality, or I should say having sex with another man, is completely illegal in both secular and Sharia law, we could only get the people who were somewhat out to come to interviews. So what we did was we shifted to online, video off focus groups, where we did the same nominal group technique. We trained everybody to create an avatar so we could actually see, you know, or they could just have a blank screen. We taught them how to take their name off of it, you know, so that they could go on. So when you're worried about that, or you're worried you're not getting generalizability, and you will sometimes get some different information, you can change the way that you do that. And then for those people who are worried about focus groups, there's something that's called asynchronous online focus groups that is, you know, that can be done where, but they have to be able to type. They have to be able to type in order to put the answers in, as opposed to speak. Or you can do asynchronous online focus groups where they do a video clip from their phone and upload it so that they can put their answers in. So there's some really emerging technologies, and it's moving. And I mean, some of them are really fun. I'm always interested in the newest shiny thing, but you know, the good old things are still good.
And I will just one comment on that. We have a lot of published papers using nominal group technique with groups of people who have a lot of stigma or discrimination against them. It really does work. And I would say that in-group stigma is probably different than external stigma, right? And my experience is that a lot of people who are using in any given region know each other anyway. Right? I mean, that there is kind of already is a community, and that can be a useful way of enhancing recruitment, really. Yeah.
Oh, God.